as possible side effect, but it's more a theoretical thing, kind of like the normal saline with the blood, you know. It could happen, you know, we think, oh, it's lactate, you know, it's lactic acid, we can make it worse. But as far as I know, it's not something that's necessarily been shown to happen.
But I also don't think you're gonna get in trouble with chloride in 2
Well,
liters either.
Right, and she did great.
So,
She
I
did great
mean,
with that.
if
And then
you're
we
gonna go either
rechecked
way, I don't-
in order to know, did she get enough fluid or does she need more? I rechecked her lactic acid and it was down to like 1.1, and she was obviously clinically doing much better. And I didn't want her to get fluid overloaded, so we just stopped her fluid. Like, we didn't give her any, but we had her, okay, you just need to drink a whole bunch
Why
of,
didn't she
you know,
do
by
it?
mouth, and she did well. So then there was an 80-year-old white female admitted for vomiting and dehydration. She came from the ER, and on her way upstairs, I think in the ER she had received a liter already of normal saline. On her way upstairs, another liter was hanging. By the time that she happened to be like down in 202 or 204, like by the time she got all the way down to the end of the hallway, respiratory came running down and said, I think she's having some trouble. And I walked down the hall, and as I got closer, I could hear her in the room going, and I was like, oh boy. And so sure enough, you know, she was fluid overloaded already, just in that short amount of time. And it's kind of like a stress test to see if anybody has heart failure. You know, we give them a whole bunch of, maybe giving a bolus while they are transporting from one area to another is not a great idea, you know. But you got to be careful with that kind of stuff. So anyways, we gave her a bunch of Lasix and we got a chest X, and she did fine. But she clearly did not need quite that much fluid. So things to remember, IV fluid can save lives, but it can also be very dangerous. So something you have to think about. They should have a time limit or maybe an estimated total amount desired, at least, you know, something that we're really thinking about. And patients should be monitored if they're starting to have signs of fluid overload. You know, they're getting all crackly in their lungs, or you see JVD, or just a lot of swelling and that sort of thing. Then, you know, let us know and we can adjust things. And then I would say the basic metabolic panel should be checked if they're going to be on IV fluids, because then you can watch their potassium, you can watch their glucose, you can, you know, check their sodium and their chloride and adjust and change, you know, the type of IV fluid if you need to as you go. And I put down this mdcalc.com. I don't know if you guys have ever been to this website, but I think it's great. It has the 4-2-1 rule in there. You just put in the patient's weight and it tells you. You don't have to figure out that 10 and 30 and all that stuff. So anyways, that is it. So a cat, IV fluid. Yeah, a cat might have some fluid. All right, so we have with us an expert panel back here. I think Dr. Eden and Dr. Tharper sort of get together.
Absolutely.
I'm just going to leave you guys back here to represent medicine. You know, so you can come and sit in this chairs if you want. And Tasha, our patient educator, is going to be our moderator. She's going to ask some questions to get the discussion started. Now, anybody on the panel is welcome to answer any question. And, you know, more than one person can answer each question. And then people in the audience are welcome to ask follow-up questions at any time.
All right, we'll go ahead and get started with this part. First question is, why do surgeons tend to prefer using LR?
Real simple. The old rule was they tended to stay intravascular better than normal saline, which is probably not true. But the second one is that especially when you're dealing with shock or trauma, the risk of metabolic acidosis is there because that Dr. Roach mentioned the hyperchloremic metabolic acidosis. And if you're monitoring a patient for perfusion and you do arterial blood gas and you see acidosis, if you don't realize they're on normal saline, you may misinterpret that as they're having problems with perfusion in their organs.
Next question, what is the maximum amount of potassium that can be in 1 liter of IV fluid? Okay, Don?
40.
Okay.
40 is the most we'll put in a liter. And we recently moved this back. We used to do 10 mil equivalents every half hour, but the St. Vincent regular, their standard of practice is to do 10 mil equivalents every hour. So that's generally where we work right now. And with different doses, we've had 80, we've had 60 mil equivalents of potassium post-op. And by doing that, you know, we can put something together. We can use 240s to run it in at 250 an hour, get 40 in every hour, or get 10 in every hour and do it twice. A lot of different ways we can kind of piece things together, or do a 40 and a couple 10s, or 6 10s if you want to do it that way.
Personally, I prefer oral potassium. Buying, and the studies have shown that IV potassium is really risky, and it,
Are you talking about acute correction, or are you, you're talking about hours, not days?
well,
Because, you know, when a patient's on the floor,
yeah,
we're talking, you know, we'd like to see their 2.9 go up to 3.1 by
yeah,
tomorrow.
but it
and so
just
giving
goes
them-
into it, when you're talking acute correction, you're talking about intravascular, but it does nothing to the it doesn't correct the potassium in the tissues.
Cells.
You're only correcting it in the blood. The tissues are still low in potassium, and that takes a long time. So I don't know how much you're really accomplishing. And you very often are putting the patient at high risk to correct the blood level of potassium. And I don't know. A lot of times it doesn't accomplish that much, I think, but from my standpoint, anyway. But, I know.
I will have to say that I'll have patients being admitted to the ER who have low potassium. They'll be put on one of these potassium boluses or something
Yeah.
like that. I'm not sure how significant
That's
that is.
particularly what I'm talking about.
I think when somebody's in the
That's
emergency room
risky.
and they've been vomiting or have whatever hypovolemic state, and the potassium is always low, is also low, and they come up with normal saline, I find that
Well, that's
curious.
correct, yeah.
And usually I will stop that and have them, I think unless somebody has acute renal failure or comes in with very high potassium, you always should have some potassium in their normal saline. if
It's
you're
those
giving them
really
some sort of
aggressive,
replacement.
it's the very
Maybe 20 or
aggressive
40.
dosages that I have a big problem with, and I think have
Yeah,
shown.
the boluses and
The
stuff like that.
boluses of the 60 have shown to be dangerous. And people think they're doing really great things, and they're not. So, to me, those are the ones that really should be.
I want to say something about red blood cells and IV fluids. Is, you know, just from the hints from Heloise, if you take some blood and put it in water, those red blood cells will lyse.
They release
If you
potassium.
mix salt in the water and put the red blood cells in, they'll stay intact. So, and I think that D5 isn't osmotic enough to make a difference. I think you have to have salt to keep the red blood cells from lysing. Whether 0.45% is satisfactory or not, or that's serious a problem, but I know D5W is a problem. I think that would be a big problem. So that, and I think that's why the standard is to use normal saline. And then you're least likely, normal saline with potassium in it, you're least likely to encounter any problems. And even if they're just on a really, really low dose, most people can tolerate a little bit of normal saline. And I think the last, though, a very important point is, you know, stop all medicine, including IV fluids, when they're done. I mean, when you've achieved your goal, stop the burn stuff. And I think as a on-call physician, you know, that's one of the things I'm supposed to do when I make rounds. And I think that nursing, certainly with this team approach, giving us reminders. This patient's been here since Thursday, Dr. Dominic. It's Saturday morning, you're making rounds. You've been on 150 ml of, you know, X, and they're eating and drinking. I think those kind of reminders are always valuable.
Next question. Why is IV fluid important when placing epidurals?
That is controversial right now. The reason that we are currently giving fluids is because when the anesthetic is injected, the bupivacaine or then Neuropen, the bupivacaine is injected, it will cause a block, and that causes the relaxation blood vessels, and it causes a blood pressure drop. Smooth muscles relax, the blood vessels dilate, and the blood pressure will drop. When the blood pressure drops, the patient gets a drop in, well, the central pressure also drops, so baby gets a drop in blood pressure. The mother also becomes symptomatic and gets nauseated and will vomit, not good. So we give fluids and we give vasopressors to prevent these two occurrences, both blood pressure drop and the symptoms. But lately they're starting to think that rather than do that, we're better off giving vasopressors rather than doing the fluid load. So right now it's a little controversial as to whether we should be giving so much fluid or giving a little more vasopressor. Right now I'm still doing the vasopressor, but it used to be we'd give 1 to 2 liters before doing
You
an
said you're using
epidural.
vasopressors?
I'm using both. I'm using the a little more conservative fluid load, more 500 tops to a liter, and watching the blood pressure very carefully, and using vasopressor if I have a response of hypertension. So that's what I'm doing right now. I'm kind of, rather than go one way or the other, I tend to use a sort of a blend, and then watch the literature and see what happens. So that's what I'm doing right now, because we tend to not all of a sudden come out one way or the other. But that is the reason we use the fluids, both for epidurals and for spinals. With spinal anesthesia, we see much more a dramatic response because it is a much more rapid anesthetic response. The epidural comes on more gradually, the spinal comes on much more dramatically, so you consequently also get a faster side effect. So that is why we do that, because of the sympathetic response of the blood vessels.
You just use ephedrine, though, don't you?
No, that's the other thing that's changed. When I was in training, we all used ephedrine, which was a beta and alpha blocker. Now, and we were told never use the norepinephrine. Now it's gone the other way. They say always use norepinephrine and never use the ephedrine, or rarely use the ephedrine.
So you get a longer acting, or, because it's pretty short too, isn't it?
They're both short acting, but one is alpha and one is alpha and beta. So you hang around long enough, things change. So, and now they're even saying, then they said bolus, now they're saying use an infusion even. So things just change. You have to watch, and things change. So we're just relying more on vasopressors.